Ladies and gentlemen, this will be kind of a personal story. The outline is as follows. I first want to share with you why I choose radiology as my field of specialty. I would like to share with you what happened since, what the current status is, and then we'll spend some time on my perspectives on AI. And a lot has been said about that already. So in 1989, I freshly got my MD degree, and I had to decide for a specialty to take because I wanted to specialize. And I was directly attracted to radiology. This is not when I started radiology. This is the first, that's 100 years before. That's the first radiograph ever taken by Konrad Röntgen. It is his wife's hand with their wedding ring. So since the introduction of imaging techniques in medicine, there has been an increasing, constant, dynamic increase in the number of examinations. I will not go over the list. There's many of them, and at the time when I had to choose for my specialty, there was really a wealth of techniques, and that really attracted me. I was afraid to be bored, and I thought, this is a field where I will never be bored. And also, what I really appreciated is at the time of my clinical rotation during my MD training, in a big department like surgery or internal medicine, typically the day would start with a meeting where the cases of the night and the day before would be reviewed, and there would be a radiologist in front of the room who would show and discuss the pictures. So the radiologist and his expertise were immediately available. And also not only for the interpretation of the images, but also discussions on what the next steps should be and whether imaging could be helpful there. And what was essential for that period is that the images, there was one set of images, one hard copy of a film, of a study, and there was a radiologist, so they were together. And also, what attracted me is this, what we currently call the value chain of radiology. Because it's not only reading films. Our profession is more than that. First of all, we are physicians on the one hand, and we have a keen understanding of imaging and technique on the other hand. And we combine that. So we're the ones who can decide if a clinical problem can be solved with imaging. So appropriateness is something we do. Then we're the experts to choose a modality to solve a clinical problem. Within the modality, you have to choose for a protocol. We do that. Then there's a whole business of running a department, and not only with scheduling patients, but also purchasing modalities, so you have to know about the techniques. Then comes the interpretation and the reporting, and finally we communicate our findings to the referring physician. So that's what we call the value chain, and we were completely responsible for that as a discipline. So what happened since I started my residency program in Leiden in 1989? A lot. So new techniques started to appear. And I have to tell you, to give you some better framing of what the state of the art was at the time. At that time, we had just a few years, we had the very first MR system of Philips in a clinical environment was installed in Leiden. So that was a fresh new modality. CT was around already, and these techniques had evolved since then a lot, and other techniques did the same. The other thing that happened is that PACS conquered the world. So suddenly we had the situation that there was no longer a single copy of an image. No, the images were distributed over the internet throughout the hospital and were available without the presence of radiologists. And what happened also, there was a tremendous increase in the production of radiology. This was the most profound one. I'll come back to that in a minute. That is the PACS development. Also, during these years, I've been involved in research. And as a researcher, apart from my clinical work, I worked with great tools. So, for example, quantitation. I just give you two examples. Quantitation is one. So here we have an image, T2-weighted image of a brain of an elderly person, and you see the white dots. The white dots are age-related changes. So we wanted, doing research, we wanted to have ways to quantify that. So there were segmentation tools. It's not very sexy anymore, but at the time, those were very new. And since you knew from each, actually you had 3D images, from each voxel you knew the dimensions, so you could quantify exactly the volume of these changes, which was new. Well, it's nice to have numbers, but numbers have to be meaningful. So if you take the left lower corner an MR of the brain of an elderly person, you can see, even as a lay person, that there is not enough brain there. So what happens with aging is you lose brain volume, but there's also brain volume loss due to specific neurodegenerative diseases. And how can you tell them apart? That you need to quantify, but also you need to compare the numbers that you generate to a normative database. And there's all kinds of ways that we all are familiar with to do that. For example, young kids during the first year, every month or so, they take the head circumference, and that's a meaningful measurement because you can plot it on a normative data set. So that is tools that we also developed for example, assessing brain volume and to assess whether it's normal or abnormal volume loss with aging. Then there's something else that really intrigued me and that we used a lot as a tool. And that's a tool that helps you to go beyond eyeballing. Because there's a lot of variation in the brain among normal people. I think I had normal PhD students, and here are 3 brains of 3 different PhD students who performed equally well, but you can see how different their brains are. And really the question is, in that variation of normal, how can you isolate the changes that are due to a disease? And a step that is used, and I will not go into a lot of details, but you can normalize in a fixed space these brains. They do not become identical, but more similar. And based on such information, you can generate an average brain. So suddenly this is a statistical map in a normalized space. If you then, for example, want to look for what is different in patients with schizophrenia, and they don't have brain tumors, so there's nothing that really pops up, then you have what you have is you can scan a number of schizophrenia patients, generating a statistical map of these patients, and then compare it on a pixel-by-pixel basis with the normative set. And then suddenly you can see what is beyond eyeballing. You cannot see it in individual scans, but suddenly you can detect the abnormalities that are out there. And what struck me during all those years that I was doing research is I had access to all these fantastic tools. Quantify, go beyond eyeballing, but none of that appeared in the clinic for a long time. We still were looking with our naked eye to images, and we would make reports, words, prosa out of that. Nothing quantitative. So what is the current status of radiology? I'm a few years older. And this is the status that we're in now. And it's not all a nice story. So there is a disconnect between the images and the radiologist. So that is due to PACS. I mean, PACS brought a lot of good things, but this was not a good thing. I'll come back to that. The other thing is consumption roars. So there's a very high demand of radiology examinations. And this is just from 1995 to 2005. And the y-axis starts at 0, so this is pretty impressive. There's really an increased workload for radiologists worldwide. And we discussed earlier the importance of the value chain. What has happened due to the increased workload is that radiologists worldwide are totally obsessed with interpretation and reporting. So that is at the expense of all the other parts of the value chain. And the consequence of that is that a lot of the examinations that are currently asked by referring physicians and that are not critically enough assessed whether they're appropriate by radiologists, because this focusing on reporting gives rise to, for example, too much radiation at a population level. So it's serious business. And all this leads to a situation that's very highly present currently, and that's burnout among radiologists. They're overworked, and they do not really experience enough pleasure from their work because they're not adding enough value. And this is a serious problem that has been recognized by the American College of Radiology. And there's numbers up to 30–40% of radiologists at the brink of being burnout. So that's not trivial. So what about AI? Is it a friend or a foe? Well, first of all, what can AI do? And in radiology, and a lot of it has been mentioned already today. There's many things, but we talked about the value chain in radiology before. I put this AI here in the middle because it can help in all the components of the value chain. It can help with decision support, so based on information from the patient, so circumstantial information, but also other information from large databases. You can almost generate automatically, based on an individual patient's information, you can generate what is the imaging step to take. Then there's business intelligence to run the department. Image acquisition techniques, MR techniques, are being fueled now and powered by AI tricks. Image interpretation goes without saying. That's the most straightforward application of AI in radiology. But also reporting, for example, actionable reporting. We no longer want to just make a report, but we also want to know, based on the evidence in the study and based on the evidence in the literature, you want to also define what is the next step. AI can help there. And also in terms of communication. So how is AI perceived by my colleagues? Well, a lot fear it. And why is that? That's because they can see that many steps of what they're doing could be taken over by AI. And also some publications do not help, and some statements from people in the field. For example, the one from Geoffrey Hinton, which is oftentimes cited. This doesn't help you be rosy about the future. But can it be a friend? And I think it can. It can help us dealing with the workload. And the workload is really the central problem of what my field is experiencing currently. So if it can take care of part of the workload, we can free ourselves to focus again on all the other components of the value chain. And then we also will be able to be more focused on innovation. Then we're living in the era of value-based healthcare. So outcome is important over cost. AI can help us dealing with both. The cost can be lowered if we can be more efficient in our whole planning, if we have to spend less time on an examination. And the outcome can be improved if we use the added value that AI is offering by extracting more out of an image than we can see with the naked eye. So it will help us move from volume to value. And also, because of all this, I'm totally convinced that it will be more fun. Just 2 weeks ago was the Radiological Society of North America meeting in Chicago, and the presidential address by Vijay Rao was addressing what AI could mean for radiologists, and it was an optimistic story, and that was most of actually the talks that I heard at the RSNA. This year, it was really all out was the story that AI will be helping radiologists. A lot of people always cite, well, it's a hype. Well, I think a lot of the things that ultimately made it into our daily lives started as a hype, but they got there anyway. I think the same will apply to AI. So what is my personal view on AI, whether it's a friend or a foe? I think it should be your friend. Because if you won't make it your friend, you will lose. Because, and this has been cited today also, actually with a different name, so I think this, the fathers of success are multiple. But AI won't replace radiologists. It will replace radiologists who don't use it. And I'm convinced that it will transform radiology back into the field that I initially chose for, where we add value, where it's fun to work, where we are visible, and where radiology is used in a responsible way. And it will go beyond that, so it will be even more fun than the field that I initially started with. So there will be more time to focus on innovation, that we can take care of the whole value chain, and we'll be again the doctor's doctor. So, because I'm convinced about this, 2 years ago we started a value-based radiology program in our department, which is really focusing, among others, on introducing AI in the clinical arena. So those are the 3 slogans that I use a lot. First of all, there was really a sense of crisis in my department, like among radiologists worldwide, because of the workload and all the other things that we're no longer doing. So I think, never waste a good crisis. It's a good starting point. Then if people complain, why do we have to do it? Why do we have to be first? Why do we have to pioneer? And then I always say, if you're not at the table, you're on the menu. And for those skeptics that don't like it anyway, if you don't like change, you'll like irrelevance even less. I think today there will be great examples of AI tools. Some of the presentations that will be given today, we will probably be implementing in our own department. So I'd like to thank Philips for organizing this meeting. And it's really exciting to see all the young new startups. And I'm convinced it will be a bright new world. Thank you very much for your attention.